So let's go to the first question. Which embryological structure gives rise to ossicles of the middle ear? So if you see, embryology per se from INI perspective is a very, very important topic, and you can have a lot of questions, whether it is ossicles, whether it is muscles, whether it is external middle ear or the inner ear. You can see a lot of questions coming from the embryological aspects. So when we are talking of ossicles of the middle ear, we know that there are three ossicles. We have the malleus, we have the incus, and we have the stapes, right? So malleus and incus come from which arch? Malleus and incus come from the mesoderm of the first arch, right? Then we have got the stapes. Stapes suprastructure, SSS. Stapes suprastructure comes from mesoderm of which arch? Mesoderm of second arch. And the foot plate of stapes come from there. It comes from the otic capsule. Now they haven't specified to you about malleus or incus or the stapes. So we are going to take it as malleus and incus and stapes together are coming from the mesoderm of the first and the second pharyngeal arches, which is the right answer. Otic placard gives rise to your inner ear. Neural crest cells, eventually they form a otic pit, otic vesicle, otic placard, which gives rise to your inner ear structure. Third pharyngeal arch is not responsible for any structure of your external ear or your middle ear or your inner ear. So this chart comprehensively tells us the important structures coming from the embryological derivative. And if you see that there have been a lot of questions also from this particular slide. So pinna comes from the mesoderm of the first and second arch, where we have got 6 hillocks, which are called as hillocks of His. Then external auditory canal comes from the cleft or the ectoderm of the first arch. Tympanic membrane comes from all the 3 layers of the first and second arch. Middle ear cleft, which is the middle ear, and the eustachian tube comes from the endoderm of the first and second arch. Malleus and incus from mesoderm of first arch. Stapes suprastructure from the mesoderm of the second arch. Footplate of the stapes gives rise to otic capsule, and mastoid comes from the squamous and petrous part of the temporal bone. So this chart consolidates entire embryology of your ear. Now let's go to the second question. Identify the joint shown in the image and what type of joint is it? So if you look at this image, again, we have the ossicles, which is the malleus, incus, and the stapes, right? So between the malleus and incus, what is the joint? And between the incus and the stapes, what is the type of joint? So between the malleus and the incus, the incudomalleolar joint is going to be which type of a joint? It is a saddle type of joint. Whereas incudostapedial joint is going to be a ball and socket type of joint. So this is again a previous year question, which is why I have given to you. So if you see here, this is the incudomalleolar joint, which is a saddle type of joint. If they would have given you incudostapedial, then it would be a ball and socket type of joint. So I'm not going to discuss more on this. Let's go to the next question. So we have a 30-year-old patient who presented to you with vertigo lasting for a few seconds. Okay, and this is aggravated by turning to the right side. In the pathophysiology of the disease, which structure in the diagram is involved? So if you see here, they have labeled something as 1, something as 2, something as 3, and something as 4. So to understand which structure is involved, first you have to get an inference of what is the diagnosis, right? So vertigo lasting for a few seconds. Where does vertigo last for few seconds? In which vertigo condition? It is BPPV. They have given to you aggravates on sleeping to the right side, further telling to you that the diagnosis is benign paroxysmal positional vertigo. So in benign paroxysmal positional vertigo, what is the canal that is most commonly involved? Yes, we all know the most common canal to be involved here is going to be your posterior semicircular canal. But they haven't asked you a direct question. They are asking you in the image which one is depicting you the posterior canal. So if we see labeling of 1, what is 1? It is nothing but your cochlea, right? What is 2? 2 is nothing but your saccule, correct? What is 3? 3 is this canal, which is your lateral semicircular canal. And what you see 4, this is going to be your posterior semicircular canal. Now, some of you may say, not agree with me. Why, ma'am? Why are you telling that this is the posterior semicircular canal? Because we've learned that the non-dilated end of posterior canal and superior canal unite to form the crus commune. So if this is your superior canal, this has to be your posterior canal, right? And this is your lateral semicircular canal. So now we know the correct answer is going to be your posterior semicircular canal, which is marked with option D, which is your fourth answer, right? So if we are revising the inner ear, we know that the inner ear has a central chamber, and this central chamber is called as vestibule. Anterior to the vestibule, in the vestibule, you have got two recesses. One is the spherical recess, which contains the saccule. The elliptical recess contains the utricle. Correct. And then anteriorly, we have the cochlea, which contains the cochlear duct. Posteriorly, we have the semicircular canals, which contain the semicircular canal duct. Cochlear duct is also called as what? Scala media. Above the scala media, we have scala vestibuli, and below that, we have the scala tympani. What is ductus reunions? This duct that connects the saccule with that of the cochlear duct, we call this duct as ductus reunions, also called as canalis reunions. Now, the saccular duct and the utricular duct, both of them join to form the endolymphatic duct, and this endolymphatic duct opens into this endolymphatic sac. The semicircular canal ducts, where do they open? They open in the utricle. Via how many openings? Via 5 openings. What are the 5 openings? This is the first opening of the posterior semicircular canal, which is ampulated. The non-ampulated ends of the superior and posterior canal unite to form the crus commune, and this is the second opening. This is the third opening of the non-ampulated end of the lateral semicircular canal, ampulated end of the lateral semicircular canal, and ampulated end of the superior semicircular canal. So now we know the entire inner ear, correct? Now the content inside, which is the cochlear duct, ductus reunions, endolymphatic duct, semicircular canal duct, all of them forms the membranous labyrinth. The bony covering over it, we call it as the bony labyrinth. Now we have a bony covering over the endolymphatic duct as well. So this bony covering over the endolymphatic duct is called as vestibular aqueduct. And similarly, we have another duct which is called as the cochlear aqueduct, which connects the scala tympani with the subarachnoid space. So we've learned that perilymph enters the inner ear. Via which duct? Via the cochlear aqueduct. What is perilymph? It's an ultrafiltrate of CSF. What is endolymph? Endolymph is produced and reabsorbed by which structure? It is produced and reabsorbed by stria vascularis. And where is stria vascularis? It is in your scala media. So I think this gives you a good revision of your entire inner ear. Right, now let's go to the next condition, which you see here in the image. True about this condition is all except. Staphylococcal infection is the most common site. Repeated such infection must indicate the clinician to look for diabetes. Tragal sign is positive. Involves the bony portion of the external auditory canal. So we are going to discuss this question. Some of you have told B, some of you have told it as D. So basically, what are we seeing? You're seeing that there is a projection here, which is nothing but the furuncle. What is furuncle? Staphylococcal infection of the hair follicle. We call it as furuncle. And whenever there is a repeated, somebody is having repeated such infections, you should think of underlying some immunosuppressive condition like diabetes or any immunocompromised state. What is tragal sign? When you compress the tragus, if the patient winces in pain, we call that as tragal sign, and it is positive for any otitis externa, whether it is localized or generalized otitis externa. Does this involve the bony portion of the external auditory canal? No. Where do you have these hair follicles? These hair follicles are present only in the cartilaginous portion of the external auditory canal. They are not present in the bony portion of the external auditory canal. So that is your false statement. statement. Rest of the three statements are absolutely true. So the learning question here is, you need to know the image, you need to know the organism, which is Staphylococcus. You should understand that there are hair follicles only in the cartilaginous part. And if somebody is having repeated such infections, you should look for underlying conditions like diabetes. So diffuse otitis externa is also a condition which we see in the external auditory canal. It is called as swimmer's ear, Singapore ear, and tropical ear. Here we see that the pain versus on tracheal pressure or jaw movement. The same is applicable for localized otitis externa as well. But here the organism is Pseudomonas and not Staphylococcus. Localized otitis externa, it is in the cartilaginous portion of the external auditory canal caused by Staph aureus. It presents to you with severe pain and a swelling. Both of them require antibiotic and sometimes even incision and drainage for furunculosis. So I hope that question is sorted, and we've also learned about diffuse and localized otitis externa. Let's quickly go to the next MCQ. A 60-year-old female presented to you with difficulty in understanding speech and imbalance. During routine ENT examination, the examiner observed loss of sensation in the region marked in the diagram. Which nerve is involved? You're thinking about a retrocochlear pathology, because whenever the word is given difficulty in understanding speech, this is often a very important point that should tell you that we're discussing on retrocochlear lesions, right? And there is imbalance, further telling us that there is some problem in the retrocochlear pathway. So what retrocochlear pathway presents to you with imbalance, difficulty in understanding speech, hearing loss? It is nothing but your acoustic neuroma. Now, in acoustic neuroma, we have loss of sensation in the region of concha. What do we call that sign as? We call that sign as Hitzelberger sign, correct? And now they're asking to you, why is there loss of sensation and which nerve is involved? So here we know that the region of concha is supplied by the sensory root of facial nerve and the vagus nerve, the Arnold's nerve. So the correct answer is facial nerve, sensory root. Okay, motor root supplies the facial muscles. Auriculotemporal nerve is responsible for supplying the anterior and superior part of the helix and the upper part of the pinna. And then you have got the Arnold's nerve, which also supplies the region of concha. But if you have to infer with the question, in exam, you might get confused thinking an image-based question, region of concha, both could be the right answers, facial nerve and Arnold's nerve. But why Arnold's nerve is not given answer? Because we're talking of acoustic neuroma and the Hitzelberger sign that is being discussed here. And the answer has to be the facial nerve, sensory root. Okay, so now if we see understand the nerve supply of the pinna, again a very important previous year topic. The lower half of the pinna, whether it is the medial side or the lateral side, is supplied by greater auricular nerve. The upper part anteriorly is supplied by auriculotemporal nerve, and very less portion of the pinna is supplied by lesser occipital nerve. The region of concha is supplied by 7th nerve and 10th nerve. Yes, lag 7 and 10, Himanshu, that's the right answer. That is what we learn in nerve supply of the pinna. So I think that's sorted. So we've learned pinna, we've learned external auditory canal, the bony and the cartilaginous part. We've learned hair follicle is only in the cartilaginous part, bony part does not have it. And we've learned about, the embryology aspects as well. We've learned about the inner ear as well. So I think that's a good revision for your ear chapter. Now let's go to the next question. During cortical mastoidectomy, failure to identify supramastoid crest will result in injury to facial nerve, incomplete clearance of the disease from mastoid air cell, damage to the cochlea, CSF leak from tegment tympani. So whenever we think of Mac-Evans triangle, there are 3 lines. The first line is your supramastoid crest. This supramastoid crest basically defines your tegmen. Meaning, if you drill above the line, you're going to enter into the cranial cavity and you could have CSF leak as well. The second line is an imaginary line that you draw across the posterior wall of external auditory canal. So this is your external auditory canal and you've drawn an imaginary line to the posterior wall of external auditory canal. The third line is a tangential line that you have drawn to the first line and second lines, right? So this is your first line. This is your second line, and this is your tangent that is drawn to the first line and second line. So the first line is representing your tegmen, the imaginary line is representing your facial nerve, and the tangential line represents your sigmoid sinus, which drains into internal jugular vein. So we don't drill above this line as we may go into the middle cranial fossa. We don't drill posterior to the tangential line as this might damage the sigmoid, and you don't go over the line across the posterior wall of external auditory canal as it may damage your facial nerve. So we know that the answer for not identifying supramastoid crest will result in CSF leak. If they had given the same question with imaginary line from posterior wall of external auditory canal, then your answer would be facial nerve. And incomplete clearance of mastoid air cells happens in corner's septum. What is corner's septum? It is persistent petrosquamous suture line, right? And when you have that, it can cause incomplete clearance of the disease. So I think now that's a good revision for corner's septum, McEwen's triangle, its boundaries and its applications, right? Now let's go to the next question. Auditory brainstem response primarily tests the integrity of outer hair cells of the cochlea, spiral ganglion, brainstem auditory pathway up to the inferior colliculus auditory cortex. So they're giving you a question on BERA, which is a very, very important topic, and asking you what does this primarily test the integrity of? Auditory brainstem response, or BERA, is a test used for identifying retrocochlear lesions. So whenever we're talking of retrocochlear pathway, we are trying to identify from the eighth nerve up to up to your inferior colliculus is what we test in BERA. So we are trying to identify the brainstem pathway up to the level of inferior colliculus. To test the outer hair cells of cochlea, we use a test which is called as otoacoustic emissions. Auditory cortex, if you want to understand whether the cortex is receiving signals or not, then you do CERA, which is cerebral evoked response audiometry. What we are talking is BERA. What does B stand for? Brainstem evoked response audiometry. So you're evoking the brainstem and recording a response. And if you want the same response to be recorded from cerebral cortex, then you do a CERA. For spiral ganglion, there is no specific test that is done. And now quickly to understand BERA, the child is asleep. It is the investigation of choice for assessing hearing loss. Yes, in children and infants, it is the investigation of choice for confirming the hearing loss. And here the child has to be asleep. Multiple electrodes are placed over the child's head. Where sound signals are given, the brainstem will receive those sound signals and there will be electrical activity in the brainstem from the auditory pathway to the brainstem. And we see that it's a non-invasive and an objective test for hearing. So here we get 5 to 7 waves, ideally 7 waves, which can be remembered with the mnemonic E coli, right? What is E coli? The first E comes from the distal part of the eighth nerve. The second E comes from the proximal part of the eighth nerve. C is for cochlear nucleus. O is for superior olivary complex. L is for lateral lemniscus and I is for inferior colliculus. Okay, so this is the way you identify 7 waves in BERA. Okay. So Sudeep, CERA can access the auditory cortex. It is definitely possible. In real life, we do CERA also. But in infants and children, it is not easy to discriminate the cerebral cortex waves versus the waves that we see from the, regularly, like the alpha, beta, delta, theta waves, all that waves that we see on EEG. Those waves are difficult to distinguish from that of the waves that we want to assess in hearing in infants. We do CERA only if on BERA we get inconclusive results, then we go for CERA. And it is not an easy way to do in children, especially. Having said that, they cannot hold so many electrodes, as many as it requires in CERA compared to that of BERA. So there are various technical problems, there are various challenges when it comes to inferring the results, which is why BERA has become the investigation of choice. Okay. A 22-year-old patient has lesion involving the primary auditory cortex. Again, a previous year question. On the left side, what is the expected deficit? Complete deafness in the left ear, complete deafness in the right ear, bilateral partial impairment, more marked on the right side, bilateral partial hearing impairment, more marked on the left side. What do you think is the answer? See, finally, the auditory pathway will go to the cerebral cortex, right? So in both the cerebral cortex, we have got the auditory cortex, which is your primary auditory cortex. Now, in your auditory cortex, there is a lesion, okay, in the superior temporal gyrus. Now, if you have a lesion on the left side, what is going to be expected? we have cross fibers going from both the sides, from the right side also, from left side also, to both the cerebral hemispheres. So definitely there will not be a complete hearing loss. That is for sure. So these two options are gone. Now, there will be a partial impairment in hearing, more marked on the contralateral side. So, if we are talking of the left side, hearing loss will be more on which side? Towards the right side. So, primary auditory cortex is the Heschel gyrus in the superior temporal lobe. It receives bilateral innervation because of multiple decussations at the level of your trapezoid body, at the level of lateral lemniscus, inferior colliculus. There are multiple decussations that happen. And as a result of which, bilateral hearing loss would not happen if only one side of the cerebral cortex is involved. Okay. Now, if there is a unilateral lesion of the auditory cortex, it will not cause complete deafness. It will cause partial hearing impairment, more pronounced on the contralateral ear. Okay, so these notes I have just added so that finally when you're reading through the PDF, it should be more easier and it's more easier for me to finish the session also. Okay. Which of the following contributes to the maximum transformer action to the middle ear? Lever action of the ossicle, curvature of the tympanic membrane, area ratio of the tympanic membrane to the footplate stapes, round window, phase cancellation. We've learned that there is a transformer action, what happens in the middle ear. So the middle ear has to transform the sound so that it's able to penetrate the fluids of the inner ear. So there are two things. One is the areal ratio, where we see that the area of tympanic membrane is larger than that of the footplate of the stapes, allowing the sound condensation. This is one way. The second one is your lever ratio, where you have got the ossicles, malleus and incus, where the sound travels from a larger ossicle to a smaller ossicle, helping in more condensation of the sound waves. Now, what is the difference in the amount of effect that it produces? Here we see that the effective vibratory area of the tympanic membrane is 45 millimeters square. Foot plate area is 3.2 millimeters square. So the ratio is 14:1. Whereas the lever ratio between the malleus and incus is 1.3:1. So if I ask you between the two, which gives you maximum transformer ratio, then it is going to be your area ratio. Okay. So I hope this is clearly understood for all of you. So effective vibratory area is 45, foot plate area is 3.2, aerial ratio is 14:1, lever ratio is 1.3:1, and total transformer ratio is approximately 18:1. If you take this as a variable, vibratory area could be 45 or 55, could be somewhere in between. If you take 55, then the ratio will be 22:1. So this is a very important chart for you to remember. So Indraish, we will be coming to all the surgeries and everything as we keep doing the class. I have incorporated all of that through the session, right? So let's go to the next question. A patient has severe unilateral SN loss and performing Rinne's test on the affected ear. The risk appears negative. This is due to true conductive loss, cross hearing through the bone conduction of opposite ear, masking effect of ambient noise, patient misunderstanding the test. Yes. So whenever we see the word severe unilateral SN loss, what happens to Rinne? Rinne is not truly negative, but the Rinne is false negative. And why is the Rinne false negative? Because of cross hearing. So when you vibrate a tuning fork and put it on the mastoid, from the same mastoid, the sounds will not be conveyed to the inner ear because there is a severe SN loss. But through the opposite mastoid and opposite cochlea, the sounds will be conducted and hence the bone conduction will still be heard by the patient. But when you put for air conduction, it will not be heard. So BC is greater than AC, which is Rinne negative, and this is not truly negative. This is false negative Rinne. So this is your answer. So quickly, if we had to recall Rinne's test, Rinne negative is seen in which, Rinne positive is seen in which condition? And then if Rinne is negative at 256, 512, 1024, what is the amount of hearing loss? Okay, let's do it this way. Rinne negative at 256 but positive at 512 and 1024. Negative at 256 and 512 but positive at 1024. Negative at all the three frequency. How much is the hearing loss? Correct. So negative Rinne is seen in conductive hearing loss. Rinne positive is seen in two conditions, which is normal or SNHL. And then whenever you get Rene negative at 256 hertz, but positive at 512 and 1024, what is the amount of hearing loss? Approximately 15 to 30 dB. Negative at two frequencies, but positive at 1024, then it is 30 to 45 decibels. And negative at all the three frequencies, it is more than 45 decibels, right? So we've revised the Rene's test. I hope all of you have got it. Great. A 45-year-old man has poor speech discrimination scores. I've already told you, whenever you have a poor speech discrimination score, what should come to your head, guys? Think about it. Audiogram is given. What is the most likely diagnosis? Please think about it. Whenever we talk of poor speech discrimination, which pathologies are we thinking of? Cochlear pathologies or retrocochlear pathologies? I want you to think about it. Yes, retrocochlear. So if I'm thinking of retrocochlear, mean ears and otosclerosis are out of our list, because we know that mean ears is the disease of inner ear, otosclerosis is a disease of middle ear. So those both are out of our list. Now we're left with presbyacusis and acoustic neuroma. Why not presbyacusis and why am I thinking of acoustic neuroma? Both of them are retrocochlear pathology. If you see the graph, it is unilateral. If you see the left ear graph, it is normal. AC and BC are present in between 0 to 20. But if you see the right ear graph, it is abnormal. So left ear normal, right ear abnormal. It indicates unilateral SN loss, which is more specific for acoustic neuroma. In presbyacusis, age-related sensory neural hearing loss, here you'll have bilateral SN loss, not unilateral SN loss, right? So both of them are very close options, but how did we identify it? By identifying which condition is unilateral and which condition is bilateral. So the downsloping can be seen in presbyacusis, can be seen in acoustic also. There is no specific reason for us to tell that only downsloping graph is presbyacusis. But the point to take home here is whenever you have unilateral SN loss with poor speech discrimination score, then it is acoustic neuroma over presbyacusis. Presbyacusis age related. Why would somebody have 1 year normal and 1 year abnormal? Aging will cause both the ear to become abnormal, right? So it's very rare or unlikely that there is a unilateral involvement in presbyacusis. Got it? I hope this is clear to all of you. Let's answer this question. A 32-year-old patient presents to you with left ear SNHL since 3 days. PTA is showing you the following. Which of the following statements is true? What is our diagnosis looking at the audiograms that are given here? This is your right ear showing AC and BC both are abnormal. So we are thinking of SNHL, right? Left ear is normal. Okay, I'm sorry, here the term had to be right SNHL, not left SNHL, okay? And the left ear is normal because AC and BC are present in the normal range of 0 to 20. Okay, only at 1 or 2 frequencies it's abnormal, but otherwise they're in the normal range. So if there is a unilateral SNHL that has been there only since 3 days, and if there is an SNHL in 3 consecutive frequencies, right? So if you see at 256 hertz, there is a SN loss, 500 hertz, there's an SN loss, 1000 hertz, there's an SN loss, 2000 hertz, there's an SN loss. So if there is more than 30 decibel hearing loss, how much? More than 30 dB. If you see at all frequency, the hearing is below 30 for sure. So if there is more than 30 decibel hearing loss in 3 days, in 3 consecutive frequencies, then you're going to think of unilateral sensory neural hearing loss, which is sudden type. So sudden sensory neural hearing loss is something that should strike to your brain. Is sudden sensory neural hearing loss usually bilateral? No, it can be unilateral also. Recovery is rare with the treatment. No, recovery is very good with early treatment. The earlier you intervene, the better will be the treatment. High dose steroids are the first line of therapy. Yes. Systemic steroid and intratympanic steroid are the first line of treatment for sudden sensory neural hearing loss. Is surgery the mainstay? No, it's the steroids. And is this a medical emergency? Yes, this is a medical emergency. So I hope everyone's got this. that if a patient is having sudden sensory neural hearing loss, which is in 30 decibel in 3 consecutive frequencies for more than 3 days, it should tell you about sudden SNHL. And for sudden SNHL, ITS and high dose steroids is the first line of treatment. Now look at the first graph and tell me what is your diagnosis. See, this is right ear graph or left ear graph. Look at this and tell me. If you can see here, AC and BC. You see here, AC and BC curve are in the normal range of 0 to 20, and there is no airborne gap. What is it? Look at this. This is a BC curve which is in the normal range of 0 to 20. AC is in the abnormal range and there is an airborne gap. What does this tell you? If there is an airborne gap, BC normal, AC abnormal, what does this tell you? Yes, this is a right-sided conductive hearing loss. Now look at this. AC curve and BC curve both are abnormal. Then what do you think with no airborne gap? Yes, this is a right SNHL. Downsloping graph, usually bilateral, will be seen and we just discussed. Downsloping graph. See, in mixed hearing loss, Sudeep, you will see that there will be AC and BC both abnormal with the airborne gap. Correct? There is an airborne gap that is present. Then we say that it is mixed. AC, BC both abnormal with the airborne gap. But if BC is in the normal range, AC is in the abnormal range, then we say that it is conductive. Got it? In presbyacusis, downsloping type of hearing loss. Upsloping type of a loss is seen in which condition? Where do you get this upsloping type of hearing loss? AC is abnormal, BC is abnormal, but you see that hearing loss is more in lower frequencies and better in higher frequency. So this kind of upsloping graph is seen in which condition? Very good, Meniere's disease. And now look at this graph. BC is in the normal range, AC is in the abnormal range, but there is a dip at 2000 hertz. What does this dip tell you? It is called as Carhart's notch, which is seen in otosclerosis. Now look at this graph. BC is abnormal, AC is abnormal, and there is a dip in both BC and AC. What do you think this condition is? This notch is called as Boiler's notch, also called as acoustic dip, which is seen in, yes, NIHL or noise-induced hearing loss. So I hope all the audiograms are done to all of you. Yes, very good. Now let's go to the next question. Which of the following is a subjective test for hearing? BERA, otoacoustic emission, pure tone audiometry, auditory steady state response. You have to tell me which is a subjective test, correct? Whenever a patient is giving response, we call it as a subjective test. When we are getting a machine generated report, then we call it as an objective test. So BERA, otoacoustic emission, auditory steady state response are all machine generated reports. So they are all objective tests. Pure tone audiometry, your Rinne, your Weber, absolute bone conduction test, where you're testing AC and BC, testing for the bone vibrations, where the patient himself is giving response, that is going to be called as your subjective test, which is your pure tone audiometry. So this chart summarizes subjective and objective tests because very importantly, you can have lots of questions coming in from here. The subjective tests could be tuning fork test, it could be audiometry, it could be auditory, ABLB is your alternate binaural loudness balance test, and SISI is short increment sensitivity index. Both of them are done for identifying recruitment. And recruitment is a test for which pathology? It's for your cochlear pathology, right? And tone decay test, a test where you ask the patient to perceive a tone and if he can hear for 60 seconds or more. If he can, it means that there's a good function of the cochlear nerve. If not, there is a retrocochlear pathology. So all these four are your subjective, where the patient is giving response. Objective, machine generated. Tympanometry, stapedial reflex, electrocochleography, otoacoustic emission, and BERA. Now, tympanometry, quickly let's recall. In tympanometry, we see different graphs. Can you all tell me where do you get A, AS, AD, B, and C? Where do you get A, AS, AD, B, and C? That I have drawn here with blue, this is your A. The one that I have drawn here is AS. The one that I have drawn now with purple is AD. Correct? So A is normal. AS is seen in otosclerosis. AD is seen in ossicular discontinuity. B type of a graph is a flat line, and C type of a graph is seen whenever there is a negative pressure in the ear. So tympanometry we have revised. Stapedial reflex is to assess from your cochlea the nerve conduction that happens up to the level of your superior olivary complex. From there are decussations going to the facial nerve, and from there you'll see contraction of the facial muscles whenever you give a loud sound. So basically stapedial reflex again tests the integrity of your retrocochlear pathway. Again, it's a machine generated report. Electrocochleography is the investigation of choice for dash. So what is the investigation of choice where we use electrocochleography for? Very good. It is used for Meniere's disease. And normally SP by AP should be how much? It should be less than 30%. If it is more than 30%, it is suggestive of Meniere's disease. Now, otoacoustic emission, is it a screening test or confirmatory test in infants? It is the screening test in infants. It is to identify the outer hair cell function of the cochlea. So you're trying to assess the function of the outer hair cells of the cochlea, which assess the cochlear pathway. BERA is a test that is confirmatory test that is used for retrocochlear pathway, which we've already discussed. So I think everything has been discussed in this one slide, giving you a complete overview of the understanding of audiological tests. Tone decay test shows marked adaptation, which means that the sound is fading very quickly. This indicates we've done this now. To tell me it's a cochlear pathology, for retrocochlear pathology, for mixed hearing loss or conductive hearing loss. So tone decay test, if it sound fades quickly, it is a test that indicates to you retrocochlear pathology. For cochlear pathology, we do alternate binaural loudness balance test. We can do otoacoustic emission. We can do SISI. These are all the tests that we do for cochlear pathways. So for cochlear pathways, we can do electrocochleography, we can do otoacoustic emission, which are your objective tests. And if you think of subjective tests, AB, LB, and SISI can be done, which are your subjective tests. For retrocochlear pathway, you can do tone decay test, which is your subjective test, BERA and stapedial reflex, which is your objective test. And again, you can have lot of MCQ combinations coming from this particular slide. In ASOM, which clinical finding suggests the development of an extracranial complication? Conductive hearing loss, post-auricular swelling with sagging of the posterior canal wall, recurrent ear discharge, high fever, and irritability. So whenever we talk of ASOM, the most common extracranial complication in ASOM is going to be, yes, very good, mastoiditis. So in mastoiditis, we can have conductive hearing loss, we can have fever, we can have irritability, but the sign that tells us that there is mastoiditis is post-auricular redness, post-auricular swelling, there is sagging of the posterior canal wall. So if I ask you in mastoiditis, what is the first sign that tells you about mastoiditis? What will your answer be? And if I ask you what is a specific sign that is seen in mastoiditis, what will your answer be? Can you tell me a sign that is seen in both ASOM and mastoiditis? So sign in ASOM and mastoiditis that you see in both the condition. So the first sign is very good. It is the ironed out appearance of the mastoid. That is absolutely right. The specific sign is going to be your reservoir sign. The sign that you see in both ASOM and mastoiditis is going to be your lighthouse sign. So, right, I am hoping that all of you have understood the basics of the science in mastoiditis. Now, quickly, if we think of abscesses in relation to mastoid, and if I ask you if there is an abscess in the sternocleidomastoid, what will you call it as? If there is an abscess in the digastric, what will you call it as? And if there is an abscess in your external auditory meatus, then what is that abscess called as? Yes. The most common is going to be the post-auricular abscess. In relation to mastoid, the most common is going to be post-auricular abscess. In sternocleidomastoid, we call it as the Bezold's abscess. In the digastric, we call it as the Sittelli's abscess. And if there's an abscess in the external auditory meatus, we call it as the Lux abscess. So So I hope everyone's clear with the mastoiditis sign and the abscesses that could be associated. So briefly, the extracranial complication could be mastoiditis, it could be labyrinthitis, it can go to facial nerve to cause facial nerve palsy. The infection can go to the petrous apex to cause petrositis. Involvement of the squamous part of the temporal bone results in osteomyelitis, and blood spread results in septicemia. Intracranial complication, most common is meningitis, then you have extradural, subdural and brain abscess, and then you can have lateral sinus thrombosis and otitic hydrocephalus. So these are the brief complications. We have more questions coming on complications that we'll discuss as we go ahead with this chapter. A 2-year-old child presents to you with fever, irritability, vomiting, and ASOM. The child now develops neck rigidity and bulging anterior fontanelle. What is the most likely intracranial complication? Lateral sinus thrombosis, subdural abscess, meningitis, or brain abscess? See, all of the four what we're discussing are all intracranial complications. But here the question is, the patient was having fever, irritability, vomiting, and ASOM. Now, when we are talking of ASOM, the most common intracranial complication after ASOM is going to be meningitis. Right now, we are looking at the further part. There is neck rigidity and bulging of the anterior fontanelle, which indicates raised intracranial pressure. Now, I will rule out lateral sinus thrombosis because there will be a hectic picket fence type of fever. There will be bluish discoloration of mastoid, none of which have been given over here. Extradural subdural abscess can present to you with raised intracranial pressure, but usually they are silent and not commonly seen following ASOM. So again, that is ruled out. Brain abscess can occur commonly after CSOM and not after ASOM. And if there is a brain abscess, there will be signs of some focal neurological deficits. They will give you aphasia, hemiplegia, hemianopia. Some focal neurological deficit would be mentioned, which is not given here, and that is why now we are even more confident that neck rigidity, bulging of the fontanelle, ASOM, fever, irritability, all of this goes towards meningitis, right? Let's go to the next question. A 7-year-old child has persistent conductive hearing loss for 3 months with no history of ear pain or discharge. Otoscopy shows retracted, dull, amber-colored tympanic membrane with air fluid level. Which of the following is the next step? Yes, so they have given you hearing loss only. Have they given you any other symptom other than hearing loss? No. They have given you clinical features of SOM, dull, amber-colored air fluid level of the tympanic membrane. Yes. So, if we have a patient who has serous otitis media, the initial therapy is going to be wait and watch, right? What is the initial therapy? Wait and watch. For how long? For 3 months. After 3 months, if there is a persistent disease, then what will you do? You will do a myringotomy plus Grommet insertion. If there is an underlying cause, what underlying cause? Like adenoid hypertrophy. Have they given you any features of adenoid hypertrophy here? Like nasal blockade, mouth breathing, snoring, pinched nose, high arched palate, failure to thrive. So why would you do adenoidectomy? SOM can happen irrespective of adenoid. It could happen without any adenoid hypertrophy also. So what will be your treatment? You have to put a Grommet, only Grommet insertion. But if they would have given you words like nasal obstruction, mouth breathing, snoring, disturbed sleep, high arched palate, adenoid facies, then your answer would shift to adenoidectomy plus Grommet. So this is what I want you to learn in this classes, that they're going to trick you in the exam. You have to find out the right answer. So OME or otitis media with effusion, glue ear, serous otitis media, all of them are the same names for the same condition. Tympanic membrane is dull, it is retracted, it is gray colored, blue colored, amber colored, it could be variable colors. There's an air fluid level, there is an air bubble that you see here. Audiometry will show you conductive hearing loss and a B type of tympanogram. Gold standard investigation is pneumatic otoscopy and tympanometry, where you get a B type of graph. The first line of management is wait and watch. For how long? For 3 months. And after 3 months, what will you do? You're going to do a myringotomy with Grommet insertion and adenoidectomy only if there are underlying adenoid features. Otherwise, you won't. Correct? Okay. So now let's go to the next question. A 30-year-old presents to you with foul-smelling ear discharge. Otoscopy shows posterior superior retraction pocket with keratin debris. PTI shows 40 decibel conductive hearing loss. What is the treatment of choice? See, very easy, foul-smelling discharge. Otoscopy showing to you posterior superior retraction pocket with a keratin debris. Keratin is seen only in one condition, which is that condition where you get keratin debris in the ear. It is cholesteatoma. Yes. PTA is showing 40 decibels conductive hearing loss. And what is the treatment of choice? So the treatment of choice for cholesteatoma, we have learned time and again, is never medical therapy. You have to go for surgery, and the surgery of your choice will be modified radical mastoidectomy. Cortical mastoidectomy are done for safe diseases, like if there is a patient who has CSOM, tubotympanic type, a patient who has mastoiditis, a patient who has any disease of only the mastoid air cells, you could do cortical mastoidectomy. But if there is a cholesteatoma or if there is an unsafe type of CSOM, then you will go for MRM. Radical mastoidectomy you will do for more advanced lesions like carcinomas, or if there is a CSF otorrhea, then you will do a radical mastoidectomy. Got it? So quickly brief pointers on cholesteatoma. It will typically present to you with foul smelling, ear discharge, hearing loss, and a retraction pocket. Most common site is the pars flaccida or the attic cholesteatoma. Most common site of origin is the Prusac space, which is the space between pars flaccida and the neck of malleus. Most common site of spread is to the lateral semicircular canal. The most common ossicle to be involved is going to be your incus, long process of incus. And the most common site of recurrence is sinus tympani, which is the infrapyramidal space. And then imaging is HRCT, that is the investigation of choice, and treatment is surgical excision via canal wall down surgery, not the canal wall up mastoidectomy. So I hope everyone is understanding about cholesteatoma. There's no problem with cholesteatoma here. Okay, now let's go to the next question. A 12-year-old boy with a long-standing CSOM, unsafe type, develops fever, vomiting, irritability, positive Chowstick sign, and carpopedal spasm. Which of the following is most likely? See here, they're trying to persuade you about CSOM, make you think about CSOM, but they have given away one very important point, which is Chowstick spine and carpopedal spasm, which is seen in hypocalcemia, which is nothing but your tetany, right? A similar question was given in this year NEET examination where they gave a perforation of the tympanic membrane, a long-standing perforation, and the patient had locked jaw, inability to open the mouth, and they had given tonic spasm of the limbs. That was tetanus. That was different, caused by Clostridium tetani. So they can give you CSOM with various other signs, trying to dissuade you from the correct answer, but you have to know that CSOM can present to you with complications which could be related to the ear and systemic as well. So here, because Chopstick sign and carpopedal spasm is given, your answer is going to be tetany. Let's go to the next question. A patient with CSOM develops high swinging fever, chills and rigor, and otorrhea. Fundus imaging is given. What is the most probable diagnosis? Acute mastoiditis, lateral sinus thrombosis, labyrinthitis, temporal lobe abscess. So you see that there is dilatation of optic disc, fever, chills, and ear discharge. Where do you get this? Somewhere where the intracranial pressure has increased. In mastoiditis, will the ICP increase to cause papilloedema? No. In labyrinthitis, will there be increased ICP to cause papilloedema? No. Temporal lobe abscess, can it cause? Yes. And in lateral sinus thrombosis also, can it cause? Yes. But I told you temporal lobe abscess will have focal neurological deficits. Are they mentioned in your question? No. Which is why your answer will be lateral sinus thrombosis, where we get hectic picket fence type of fever. What is the kind of fever we get here? Yes, hectic picket fence type of fever. What is the sign where you see bluish discoloration of mastoid? What is that sign where you see the bluish discoloration of the mastoid? What is that sign called as? Yes, that sign is called as Griesinger sign, where there is edema and bluish discoloration of the mastoid because of thrombosis of the mastoid emissary veins. We do two clinical tests to evaluate the raised intracranial pressure. The first one is called as the Toby-Ayers test. The second one is called as Krobig's test. So these are the tests that we do for lateral sinus thrombosis. So these four words are very important when it comes to lateral sinus or sigmoid sinus thrombosis: hectic picket fever, Griesinger sign, Toby-Ayers test, Krobig's test, and on a contrast enhanced CT or a contrast enhanced MRI, you will see a sign. What is that sign called as? Delta sign or empty delta sign. Okay, so this is about your lateral sinus thrombosis.